Hello everybody, welcome back to my channel, that is Clinical Pharmacy Practice by Dr. Ashish Shrivedi, and today I am going to teach you about the clinical toxicology of tobacco poisoning. So let's directly dive into the topic. We'll start with the introduction. What is actually tobacco and how we get the nicotine from the tobacco leaves, and here is the plant, image of the plant and the flowers. Tobacco is usually prepared from the cured leaves of Nicotiana tabacum belonging to the family of Solanaceae. Although Turkish tobacco is prepared from the leaf of Nicotiana rustica and another plant and is more potent form. Indian tobacco refers to the lobelia inflata. And what are the active alkaloids which are present in that tobacco leaves, like nicotine, nornicotine, anabasine, and anabetine. And this nicotine is mainly responsible for the CNS activation. Nicotine is a stimulant of the CNS and is abused widely all over the world in the form of inhalation, cigarette, cigar pipe, bidi, nasal insufflations like snuff or chewing. Nicotine is also used as an insecticide, although we don't use that. It is also used in de-addiction of nicotine smoking as transdermal patches nicotine gum. The use of insecticide is very less. We have other insecticides also. All the parts of the plant are poisonous except the ripe seeds. Dried leaves contain around 1 to 8% of nicotine, and an average cigarette delivers 1 to 3 mg of nicotine into the bloodstream. Okay. What is the mechanism of action? Here we have to look very deeply and we have to understand. Nicotine binds to the nicotinic cholinergic receptor, we all know, resulting initially via action on autonomic ganglia. In predominantly, firstly, it will activate sympathetic nervous system. Then with increasing of the doses, we will see parasympathetic stimulation, and lastly, we will see ganglionic and neuromuscular blockade. And direct effects on the brain may also result in vomiting and seizures. It confuses how actually nicotinic receptor we study in the parasympathetic system, but here it will stimulate sympathetic nervous stimulation and then parasympathetic with high doses, and lastly ganglionic neuromuscular blockade. It is due to the dual action of nicotine. We will get deep into this topic in another slide. It have dose related action. Moderate dose it will activate sympathetic system, stimulant activity. Higher dose it will activate parasympathetic system. However, after the activation of cholinergic symptoms, it will remain constant. Now we have to understand the ANS pharmacological concepts before we jump to the signs and symptoms. Now the concept of ANS pharmacology, we will now understand the dual action of nicotine via some examples of ANS pharmacology. Okay. Now, we see that we already studied here only that low doses of nicotine will cause the arousal and relaxation. Okay. And we see the higher doses of nicotine causes the respiratory paralysis. For the time being, you just understand and just know and just keep in this mind that low doses of nicotine will cause arousal and relaxation, and for high doses it causes a respiratory paralysis. Here is the presentation of muscarinic receptor and its work and its affinity, and nicotinic receptor and their affinity according to the neurotransmitter. Okay, muscarinic receptor, we have the highest affinity for muscarine and medium affinity for acetylcholine and least affinity for nicotine. However, nicotine also acts on muscarinic receptor. It's not the hard and fast rule that nicotine will not bind to the muscarinic receptor. It binds to the muscarinic receptor, but the affinity is very low in comparison to acetylcholine. But if we talk about nicotinic receptors, the highest affinity will be for the nicotine, and medium affinity is acetylcholine, and the lowest is muscarine. Now, if we talk about the nicotine, the body doesn't produce nicotine. In general, you understand that body does not produce this nicotinic neurotransmitter. Body doesn't produce. body produces acetylcholine. Okay, just keep in mind that our human body produces neurotransmitter that acts on muscarinic receptors and nicotinic receptors is acetylcholine. Okay, since we are studying these two receptors are of cholinergic system, or we can say parasympathetic system, or we can say parasympathomimetic receptors. Okay, these receptors work for cholinergic system, and in cholinergic system we know already that acetylcholine is the major neurotransmitter that is working for cholinergic system. Okay, now for timing you understand what the actually nicotine does when it comes into the bloodstream via smoking, transdermal patches or gums, anything. It causes the stimulation via release of dopamine, which ultimately causes us to have a feeling of pleasure. The appetite will be suppressed. Okay, nicotine will also help in release of norepinephrine. It will cause arousal, appetite suppression again. And it will also increase acetylcholine secretion that will cause the arousal, cognitive enhancement. It will release glutamate that will help in learning, memory enhancement. It will release serotonin, mood modulation, appetite suppression. Okay, and then beta endorphin reduces of anxiety and tension. Then lastly the GABA, the reduction of anxiety and tension. Okay, now remember that nicotine works according to the dose. Okay, it works according to the dose, and it do have a dual action. Okay, dual action, and we can understand by this simple concept that low doses will cause arousal and relaxation, but high doses will cause respiratory paralysis. Okay, nicotine have the dual action. Just keep in mind. Okay, it acts and works according to the dose. Okay. Now, the problem with the ANS pharmacology is that it often confuses us with lots of receptors in that, and because of the receptors, lots of neurotransmitters we listen and lots of clinical features we study, and it confuses us a lot. Even I also confused when I was a student, but later on I understood what is the basic concept behind that. Okay. To understand the basic differences and to determine which system is what and which system have the clinical features of what, we have to understand that the division of this cholinergic system and adrenergic system is mainly determined by neurotransmitter working for that system. Okay, the first thing we have to know the difference, how we can know the difference and what is the rules regulation we can understand by this is that we have to think about three things to understand the system. Okay, first, like for example, if you want to understand the parasympathetic system or cholinergic system or parasympathomimetic system, we have to understand the three things. First, what is the major neurotransmitter working for that system? Second, what are the receptors of the system? Okay, by how you will know the receptors of the system is comes under that particular system. It is determined by the from which neurotransmitter it gets activated. Like we do have a parasympathetic nervous system receptors like muscarinic receptors and nicotinic receptors. It is activated by acetylcholine only. So that's the reason that nicotinic receptors and muscarinic receptors comes under the cholinergic system, because the major neurotransmitter working for the parasympathomimetic or cholinergic system is acetylcholine. So that is the reason that we say that muscarinic receptors and nicotinic receptors are the part of the cholinergic system, because it is activated by the major neurotransmitter working for that particular system. Okay. Then third, after the activation, what is the majority of clinical features is seen. So we can differentiate sympathetic and parasympathetic system on the basis of neurotransmitter, major neurotransmitter, that what is working for that system. receptors of the system which are which get activated by that major neurotransmitter. And what after the activation of the receptor, what is the majority of clinical features that shares the sympathetic system features or parasympathetic features. Okay. Now, second thing is that we have a brain stem or spinal cord. Okay, everything starts with the brain stem or spinal cord. Let's understand, we have brain stem or spinal cord, we have ganglion, and we have effector organ on which the receptor is there. On ganglion also the receptor is there, and on the effector organ also the receptor is there. So transmission started, brainstem or spinal cord, from that transmission started. Okay. Before that ganglion we have preganglionic neuron. Okay. And on the ganglion also receptor is there. Then we have post-ganglionic neuron. In between these receptors we have neurons. Okay. Before ganglion will always be preganglion, after the ganglion will always be post-ganglionic neuron. Okay. Now, this post-ganglionic neuron will release a neurotransmitter. It could be the same, preganglionic and post-ganglionic neurotransmitter will be the same or will be the different, depend upon the activation of that receptor and what it does after all. Okay, effector organ. Now, we will move towards into the D. Now, this is the brief concept I can make you understand and make you simplify is that if you are talking about parasympathetic nervous system, what I told you in the previous slide is that we have three things to keep in mind. First is, what are the major neurotransmitters that is responsible? Okay, so we see that the major first thing we have seen the major neurotransmitter what is working for that system. Second, the receptors which are responsible after the activation and from which the particular receptor is activated. Okay. Now, parasympathetic. First, we will understand parasympathetic nervous system. Okay. Parasympathetic nervous system, the main neurotransmitter that it releases, major neurotransmitter. How you will determine the major neurotransmitter? The last neurotransmitter it releases. We will understand it. Okay. How you will determine the major neurotransmitter that is working for that system is the last neurotransmission, that is post ganglionic transmission from the post, like this is ganglion, before that is preganglionic neuron, and after the ganglion it's post. So this one will be the post ganglionic neurotransmitter. Okay. Now, how you will know from neurotransmitter that is that particular is majority working for that particular system? For parasympathetic, we see the last neurotransmitter before the effector organs it reaches or the post-ganglionic neuron is acetylcholine. Okay. Now we can understand that the last neurotransmitter or the post-ganglionic neurotransmitter is acetylcholine. So it works, or it's the system which is working for parasympathetic nervous system. So we come to know that it is working for the parasympathetic nervous system. Now, for the sympathetic, the major neurotransmitter, as we all know, is that epinephrine or norepinephrine. Okay. Now, here the last neurotransmitter is norepinephrine, not acetylcholine. Although it starts with acetylcholine, okay, but what it ends up with is norepinephrine. So, norepinephrine is the last in the postganglionic neuron, which determines that the system could be sympathetic nervous system. Now you are understanding the concept. Now, if you will move towards the adrenal medulla, so it will start with adrenal medulla, it start with the brain, brain and spinal cord, and the preganglionic neurotransmitter is acetylcholine. but the post is epinephrine, norepinephrine. So this will also comes under the sympathetic nervous system. These two comes under the sympathetic nervous system, and this one will be the parasympathetic nervous system. Okay. Now, although somatic nervous system, we say that it does not, it's a separate part or separate topic. But if we check the last neurotransmitter is what, so we see that acetylcholine is working as a postganglionic neuron, or we can't say as a postganglionic because we don't have ganglia according to the somatic nervous system, because ganglions are not involved in that. So acetylcholine will be the last neurotransmitter. So we can say that it also comes into the parasympathetic nervous system. So these two systems comes under sympathetic, broadly comes under sympathetic nervous system, and these two flow charts comes under the parasympathetic nervous system. So how you determine the major neurotransmitter? The last neurotransmitter that releases up to the effector organ receptors are used to determine that which system is activated. Okay. For parasympathetic, the last is acetylcholine. For sympathetic, although it starts with acetylcholine, but it end up with norepinephrine or epinephrine. Okay. And for somatic nervous system, it end up with acetylcholine. Now the second thing, you just understand what is the nicotinic receptor is doing here in the sympathetic nervous system. You might be thinking that why this nicotinic receptor comes under the sympathetic nervous system. How we can say that it works for, because it is working for sympathetic also. On ganglion, all nicotinic receptors are there, but we say that nicotinic receptors come under the parasympathetic nervous system. Okay. Second thing, what I told is that the receptors which are responsible for the activation is resulting from which neurotransmitter. For example, a nicotinic receptor is, if nicotinic receptor present in the parasympathetic system and majorly on ganglion, if you can see it activated by acetylcholine in this parasympathetic flow chart. Okay. Now if we move towards the sympathetic also, we can see in the sympathetic system flow chart, we can see the preganglionic neuron is acetylcholine only, same as parasympathetic nervous system. So here also the nicotinic receptors are activated by acetylcholine only. Okay. Now if we move towards the medulla receptor, so we can understand the preganglionic neuron also, or the not the preganglionic, adrenal medulla neuron or neurotransmitter, if we can see, is that acetylcholine only. So in the case of parasympathetic also, nicotinic receptors are activated by acetylcholine. So we can directly say that nicotinic receptor comes under the parasympathetic system. But in sympathetic system, we see that acetylcholine also activates the sympathetic system ganglionic nicotinic receptor. So for this reason, we have to check these receptors are activated by which receptor. These three, whether it will come under the sympathetic or parasympathetic or adrenal medulla, these three nicotinic receptors are actively activated by acetylcholine only. So the major neurotransmitter is acetylcholine for the activation of nicotinic receptor, and acetylcholine is majorly works for activation of parasympathetic nervous system. So nicotinic receptor, that is the reason that the nicotinic receptor comes under the parasympathetic nervous system, because they are activated by acetylcholine only, and the acetylcholine is the major neurotransmitter of parasympathetic nervous system. Okay. Now, I told you in the previous slide that nicotine in moderate doses, it will activate sympathetic nervous system. How it will activate sympathetic nervous system? By this flow chart. Okay. If we take nicotine will come into the bloodstream, it will come to the ganglions also, and it will bind to adrenal medulla also. Nicotine receptor on the adrenal medulla, ganglion, and these parasympathetic. It will bind to all these three. Like if nicotine comes into the blood, it will directly act on all these three receptors. So it will directly activate parasympathetic system, sympathetic also, and sympathetic innervation of adrenal medulla also. So it will activate all these three systems, and even involves the somatic system also. Okay, so what the clinical manifestations we see is that, according to that, we see first with moderate doses we see that the system which gets activated are sympathetic. With little high doses, we see the activation of parasympathetic nervous system. But in the end, we will see the blockade of these ganglion and ultimately the neuromuscular blockade. This is the nicotine and the feature of how it acts. Okay. First, it will activate sympathetic nervous system. Second, it will activate parasympathetic activation. And finally, it will block all these three receptors, which we can say as the ganglionic blockade. And lastly, neuromuscular blockade by blocking the somatic system. Okay. Here also it's written like that: ganglionic blockers specifically act on nicotine receptor, both parasympathetic and sympathetic autonomic ganglia. Okay. So here we see that how nicotine blocks finally. First it will activate sympathetic and parasympathetic, then ganglionic blockade and neuromuscular blockade. So these are all the actions to understand what nicotine will be doing if the toxicity happens with the nicotine. So we have learned that it activates sympathetic, parasympathetic, and adrenal medulla also. So we have seen the clinical features. We can imagine that the clinical features will be coming like, first one will be the sympathetic actions, and second one will be the parasympathetic action, and the third one will be the blockade of all these actions. Okay. So if we imagine the sympathetic nervous system activation with the moderate dose, what we will see? The contraction of the iris radical muscle, that is pupil, dilates. First, the pupil will be dilating, and with the higher dose, the pupil will be contracting. Okay. Then, with the moderate dose, the trachea and bronchioles will be dilated, and with high dose, constriction and increased secretion will occur. Adrenal medulla. First, it will increase the secretion of epinephrine and norepinephrine. Lastly, it will block that. In kidney, it will, with moderate dose, it will release the renin, and after that, it will block it. And so on. We will see the ureters, genitalia, lacrimal glands. Means like in moderate dose, we can't see the stimulation. Okay, tears will not come. Okay, so we can't see the lacrimation here. Okay, in moderate dose or in mild dose, we can't see the lacrimation. But as we see that with high dose, sympathetic, first will activate sympathetic system, and second with high dose it will activate parasympathetic system. So with high doses we can see the lacrimation in tobacco poisoning or nicotine poisoning. Okay, so this is kind of that. Okay, so here is the all example. You can go through that, like blood vessels. It will first dilate the blood vessels by activating the sympathetic nervous system, and later on it can block blood vessels also. First it will constrict, and afterward it will dilate. So you can understand that if the blood vessels are constricted and in sympathetic nervous system, so you can understand the sympathetic nervous system raises the BP. But if the parasympathetic nervous system activates, it will cause the hypotension. So you can correlate with these clinical features as you go further. Okay, so we already got that initially the sympathetic system will be activated. So likewise, it will share some clinical features similar to the sympathetic system. And then finally, it activates parasympathetic system with higher doses. So likewise, it will share some similar to the parasympathetic activation. Okay. So, and so on. Then with ganglionic blockade, we will see neuromuscular blockade, we will see. Ganglionic blockade is nothing but all blocking of these both systems. If we block these both systems, what will happen to that patient? It depends upon that. Okay. So, this is the chart you can understand with this. First, we have seen that sympathetic nervous system will be activated, so we can understand that BP will go high, pulse rate or heart rate will go high, respiration will go high, it will increase, and temperature will also be increased. Mental status, the patient will become agitated, and the pupil size will also increase. Peristalsis will be normal or it will increase, or diaphoresis will increase, and tremor and seizures with more and high doses as it will achieve with high doses. And lastly, finally, it will activate parasympathetic system. With the BP will be the fluctuating, and it will be variable, whether it can become high or it can become low, extremely low. And in that case, hypotension, we will see more. Pulse rate will go down, the patient will experience bradycardia in higher doses. Respiration can become, it can be normal or it can increase. Okay, temperature will be the normal, and normal to depressed patient will become depressed actually clinically. The pupil size will be is changing. It will be like dilated or constricted depending on the patient and what it's experiencing at that point of time. Peristalsis will increase, diaphoresis or sweating will increase. And other things we can understand by sludge that I already told, that if cholinergic system or parasympathetic system or parasympathomimetic system activates, we can see sludge. That is salivation, what it stands for. S for sludge, L for lacrimation, U for urination, D for diarrhea, B for bronchoria, L for lethargy, M. Okay, sludge up to this only. Then we will know muscle fasciculations and paralysis. If we can add these things also, because sludge don't cover all the clinical features. Okay, now what are the sign symptoms the patient will be experiencing? Now you understood already that sympathetic nervous system it activates, then it activates parasympathetic system. Then finally it will block all those sympathetic and parasympathetic system. Just imagine if the body's sympathetic and parasympathetic system will be blocked. So what it happens? All things will be collapsed. All working will be collapsed, and the patient can be. It could be possible that patient can die from respiratory depression or arrest. And respiratory depression or arrest is the main thing to be in concern for the clinician, because mostly the tobacco poisoning, if patient had a large amount of doses of nicotine or poisoned by nicotine, it could be possible that patient can die from respiratory depression or respiratory arrest. Because I told you, if just imagine if sympathetic and parasympathetic, both the systems got blocked, so both systems will not work. Okay, so everything will be collapsed, all the organs will be collapsed. So if we summarize both the system, like parasympathetic nervous system and sympathetic nervous system, will get to, it's not in sequence wise, like you don't imagine it that these sign symptoms, don't imagine like what we can say that it will be sequential. It is not in sequence, it is just a summary to make you understand. It's not in sequence, so don't make it that. And moreover, it comprises of the major sign symptoms, what we can see clinically in that patient. The patient will be suffering from dizziness, nausea, vomiting, diarrhea, pallor, skin will become paler. The patient will be experiencing diaphoresis, abdominal pain, salivation. And here from salivation you can understand the cholinergic system, when parasympathetic system or cholinergic system activates, we can see salivation. So you can understand or you can correlate your concepts that the salivation could be possible due to the high dose of nicotine. And if the patient experiences low doses of nicotine and toxicity with low doses, then parasympathetic system will not be occurring. Parasympathetic nervous system clinical features will not be occurring. So if the patient is suffering from salivation, it could be possible that patient had a high dose of nicotine. Okay. Now lacrimation. Okay. Lacrimation is there. Muscle weakness. Pupil gets dilated or constricted. Okay. Like here you can see that dilation and this is constriction. Patient will get initial tachycardia and hypertension due to the activation of sympathetic nervous system initially. So he will experience tachycardia and hypertension, but it will followed by bradycardia and hypotension due to the activation of parasympathetic system. So patient initially he will present with the tachycardia and hypertension, and finally it follows the bradycardia and hypotension. Okay. What the patient will experience in severe cases, in the severe and high doses of nicotine or tobacco. The thing you have to keep in mind, and you have to make a patient to be monitoring the vitals of that patient ongoing, is that the thing you have to make mainly you have to make it what we can say a point in your mind that if the patient is suffering from confusion, agitation, lethargy, convulsions, then the patient's case is very severe. Patient can die easily. Okay. So if you see a patient of tobacco poisoning who have the confusion, agitation, lethargy and convulsions, treat him in a short span of time, otherwise he will die. And I already told you that respiratory muscle weakness and respiratory arrest, if it happens in the patient, then it could possible that the patient can die, because first it will activate sympathetic, then second it activates with higher dosage, it activates parasympathetic. And if he had consumed a large amount of toxic dose of nicotine, so I told you that it will cause a ganglionic blockade and neuromuscular blockade. So with ganglionic blockade and neuromuscular blockade, the respiratory muscle can become weak and finally it can cause arrest. And if the patient enters into the respiratory arrest, he can die very, very, very easily. So we have to make sure that patient should not suffer from the respiratory arrest muscle weakness. We have to monitor the vitals and pulse oximetry and SpO2. We have to measure SpO2 and we have to keep monitor on SpO2. So these are the concepts which you have to keep in mind. So we just now in previous slide we learned about the basic concept of ANS pharmacology that we can understand in nicotine poisoning. Diagnosis entirely depend upon clinical findings and history. Okay. Other laboratory studies we can check is that electrolytes, glucose and arterial blood gases or oximetry. I already told what is the importance of oximetry. Now coming over the management. Management includes the emergency and supportive measures. In that, we have to maintain the open airway and assist ventilation. It is very necessary. And we have to administer supplemental oxygen. We have to treat seizures, coma, hypertension, and arrhythmias if they occur. Anything can occur, hypotension or hypertension, and arrhythmias if they occur. Observe the changes in the vital signs we have to observe. We do have antidotes like mecamelamine. It is actually a specific antagonist of nicotine action. However, it comes in the tablet form. So if the patient is suffering from vomiting, convulsion, or hypotension, we can't give them. Decontamination we can do if the patient is suffering tobacco poisoning from skin and eyes. We have to remove all those contaminated clothing and wash with the copious soap and water. We have to irrigate the exposed eye with copious saline or water, like in the case of transdermal patches. The patient has ingested a large amount of tobacco, so we have to administer activated charcoal orally if the conditions are appropriate. Gastric lavage is not necessary after a tobacco ingestion if the activated charcoal can be given promptly. Okay, consider gastric lavage for large recent ingestion of liquid nicotine. For asymptomatic small quantity cigarette gut decontamination is not necessary. For ingestion of nicotine patches and these and all, we can go for whole bowel irrigation or activated charcoal. In enhanced elimination, it won't work. These procedures are not likely to be useful. Enhanced elimination is not useful in the case of tobacco poisoning. Okay, because the reason is that it has the half-life very large and volume of distribution. Half-life is short. Half-life is short and volume distribution is very high. That is the reason. Thank you. And I want to just add, if you like my video, please subscribe and tell me in the comment box if you like or not. Okay then, bye bye.